Hello, and welcome to Ask the Doc. If you're new to the program, this is a live monthly show that UCI Mind hosts where we invite our viewers to ask questions of our experts in Alzheimer's and dementia research. My name is Dr. Megan Wickbrocht. I'm the Associate Director of Education here at UCI Mind, which is part of a national network of Alzheimer's disease research centers designated by the National Institute on Aging, which is part of the National Institutes of Health. Today, we are fortunate to be joined by Dr. Michelle McDonnell. She is a clinical neuropsychologist at the UCI Mind Alzheimer's Disease Research Center. She received her master's degree and PhD from Loma Linda University, and then she went on to complete a postdoc fellowship at the Loma Linda VA Hospital. She's been with UCI Mind since 2020, and let me add, she's a licensed psychologist. So welcome, Dr. McDonnell, and thank you for joining us.
Hi, thanks for having me.
Yes. And welcome to our live viewers. If you're attending live on Facebook or YouTube, you can participate in the Q&A with Dr. McDonnell by typing questions in the comments box accompanying this video. Please do note that everything lives on the internet, so don't post, or please do post responsibly. So with that, let's get started. Dr. McDonnell, what does a clinical neuropsychologist do?
Yeah, that's an excellent question. A lot of people don't know what we do, and a lot of people don't know that this career even exists. If you ask my family, they don't even know what I do. So it's not uncommon for people to really be speculative about this job. But a neuropsychologist really assesses how a person's brain is functioning. So someone can get a brain scan, and that can kind of show some areas of change or damage, but the area of change or damage does not always equal functional impairment, right? So they may still be able to live independently, manage finances, drive. They maybe don't even have any cognitive complaints, right? Alternatively, a person may have a clean brain scan. And there's nothing really significant on those findings, but they have significant functional concerns or cognitive complaints. So we look at how a brain may be functioning in day-to-day life. So we do lots of paper and pencil tests and things like that and assess all sorts of different cognitive domains. And that tells us how a person's brain would be functioning relative to day-to-day life. The pattern on those results then tell us kind of what type of diagnostic concern is causing that. So Alzheimer's disease, dementia with Lewy bodies, these things come up with patterns. So in short, what we do is we take somebody's brain for a test drive, run some diagnostics, and figure out what might be going on under the hood.
That's great. Okay, what are the domains of cognition and how are they measured?
Yeah, so there are many different areas of cognitive functioning and many different cognitive domains, and the ways to measure them is actually pretty limitless. It really comes down to the area of concern, the specialist preferences. Clinical neuropsychologists have their own preferences, just as a neurologist would, etc. But I think in the most general sense, some of the most commonly assessed cognitive domains can actually include something called premorbid functioning, right? So this means assessing how your brain was likely functioning prior to any concern, prior to an injury or illness, right? And this is assessed very differently in other clinics. But the purpose of it is to really figure out how we expect a person to have been functioning kind of in their prime. Most people don't come in to a clinic having a baseline neuropsych eval, right? So it's hard to compare you to you without that. So this serves as a comparison of you to you. We also assess things like attention and concentration, right? So this domain simply tells us how well somebody can attend to the stimuli and even mentally manipulate that information. So think of being able to hold a phone number in your head while you write it down, or being able to subtract numbers or even swap the order of those numbers, right? That's all really attention and concentration. And attention and concentration is essential because it really is the first piece of the memory process, right? If you're not paying attention to the information, how do you store it, right? And then how do you later retrieve it from the filing cabinet in your brain? So that. We also assess things like processing speed. So this is how quickly your brain is firing, how quickly you react to information, how quickly you can pull this information out of your memory, all of those things. Another domain is language, and language is a very complex thing to assess, and it's assessed very differently depending on the presenting problem, right? Overall, we want to assess a person's ability to comprehend language and produce speech. So thinking about a person who had a recent stroke affecting their language centers, they may have difficulty physically producing speech, maybe even understanding speech, or even producing speech that aligns with the topic at hand, right? So we want to kind of assess where is the disconnect in the language centers. Here at UCI Mind, we focus on a bigger picture of language. So we definitely assure that they can comprehend us as examiners. And then we evaluate their ability to name objects and produce words that belong in a certain category with very specific rules. So how quickly these things can come to mind and their word finding ability. Other domains we assess, again, there's a lot, but we do assess visuospatial functioning, right? So we want to be able to assess how somebody can visually manipulate and interpret the world, right? For people who have always been visually capable, being able to use the environment to find the elevator, press the button, all of those things can be impacted in some ways. So we want to make sure that they're still able to do all of those things. The biggest thing that everybody's always concerned about is obviously learning and memory, right? So in both verbal and nonverbal formats, we assess this. The goal is to see how well you learn information, right? So do you need repetitions? Does context help, right? Like a story, a conversation. Is there a difference in your ability to learn verbal versus visual information? Where are your strengths and weaknesses with learning? Then we assess memory and see if the patient is able to recall the information that they learned. So if there's any difficulties or variabilities, this can tell us where in the memory process the problem lies. And then the last domain that we're really interested in here as well is executive functioning. Okay, and this is how well somebody can multitask, shift between tasks, ignore distractors, problem solve, think abstractly, all of those things. So this can be done by making people do two things at a time, making people solve some complex problems, or even identify like an abstract concept, whether it's written or in a visual picture.
Mm-hmm. Very good. Wow, it's extensive. Okay, so what kind of changes in memory and other thinking skills are part of normal aging?
Yeah, a lot of people can become pretty alarmed by natural changes in aging. So just as we get gray hairs on our head, our muscles and stamina decline, our brain goes through some natural aging as well. And this is why it's important for us to compare a person's scores on a neuropsych exam to their same age peers, right? Just as we wouldn't expect an 80-year-old to go out and run a mile just as quickly and efficiently as an 18-year-old, we can't expect an 80-year-old brain to function the same as an 18-year-old brain, right? And that being said, there are some natural changes that occur that is not necessarily suggestive of a disease process. So some of the natural changes can include slower processing speed, right? Meaning that you need more time to think, respond, react, problem solve, right? It just runs a little bit slower. Naturally, when we physically run, we're a little bit slower as we get older, so that kind of is easy to understand. Somewhat related is also the fact that it takes longer to learn information. So it can take a little extra time for your brain to send that information into storage. There's also some reduced free recall. Now, for example, if I read a list of words to an older adult and asked them to tell me those words after 20, 40 minutes, they won't be able to remember as many words as their younger counterparts, right? But if I give them clues or hints, they can remember all of the information. So it's not forgotten. I just need to provide a cue to help that information come to light. And then lastly, there's definitely some reduced sustained and divided attention. So this can look like difficulties maintaining your attention as well as some increased distractibility. So this means that it's a little bit harder to do more than one thing at a time. So especially if it's a more complicated thing. Tax season is coming up, unfortunately. So I think about kind of putting all of your tax documents together. For older adults, it may be a little bit harder to do that while having a conversation, while watching TV, while listening to music. Whereas in the past, it was much easier to do that thing while having a movie playing in the background. So those are some of the natural changes that we experience with aging.
Great. We actually have a question from our audience, which is
Good.
exciting. Which domain or domains of cognition and function is important for addressing mild cognitive impairment?
I think that they are all important because they all tell me a different story, right? Different causes of mild cognitive impairment tell me a different pattern. So I kind of need all of those things to be able to say, is this a kind of earlier stages of an Alzheimer's process? Or am I concerned about something like dementia with Lewy bodies? Do they have sleep apnea? And this is causing some significant cognitive concerns, right? These all give me a different pattern. So I would definitely want to be able to assess all of them.
Yeah. Now, in Alzheimer's, what cognitive domains do you usually see decline first? I know you mentioned attention, but what are some other areas?
So with attention, there's like a natural decline, but in Alzheimer's disease, attention usually remains intact longer than most other things, at least sustained attention. Things that decline earlier in the process tend to be things like learning and memory. They don't really respond well to cues and reminders, as well as language, right? So being able to name objects and things like that, there's this feeling of it's harder for me to think of the words to say above and beyond what's normal for your same age peers. So those seem to be the two major domains that decline first.
Executive function and language, or memory and
language.
I see. Okay.
Mm-hmm.
Great. So what is the first step someone should take if they're having memory concern?
Yeah, I mean, there are hundreds of things that can impact memory, and some of them are actually reversible and manageable. So my first piece of advice would actually go to a primary care provider and let them know what you're experiencing and some of your major concerns. And I would be upfront and honest with them and really describe what you're experiencing, because that can tell them what they need to do next. But some of the things that they'll probably do right out of the gate can include blood tests for vitamin B12, thyroid levels, a complete blood count, even some comprehensive metabolic panels, things like HIV testing. They do all of those things to see if there's a reversible and or manageable cause, right? They will also ask you some questions, particularly about sleep. So if you're experiencing insomnia or sleep apnea and you're not treating that, that can impact how your brain is functioning in your day-to-day life, right? Imagine if you're very tired, your brain can't quite work as well as it should. They may ask you some questions about your mental health, thinking of depression, anxiety, PTSD. Again, those things can impact your cognitive functioning in your day-to-day life, but it's very manageable and fixable in a lot of ways. At that point, when they kind of get a better understanding of what you're experiencing, run some diagnostic tests, they may even do a cognitive screener. Okay, it's really quick, 10 to 15 minutes. And if that screener is below what we would expect, kind of below that threshold, at that point, some recommendations may vary. So they can make some recommendations to treat some of the concerns that they already saw, whether it's low B12 levels, or they may want to send you to more follow-up. So they may refer you to a neurologist, which is excellent. This is where they specialize. They are our memory doctors. We work hand in hand with neurologists every day. Those are our partners in the field, really. At that point, a neurologist may ask you to have neuroimaging if it's indicative based on your concerns and your complaints. And then at that point, you may even be referred to us. So when people have concerns about memory, things like Alzheimer's disease or dementia with Lewy bodies, those things are best determined after most other things have been ruled out. So you want to make sure that you rule out all of the potential other causes and then come to our clinic. We integrate all of this information and consider it. So we want to make sure that all of those things have been addressed so that we don't misdiagnose somebody.
Yeah, great. So then when people come, what's involved in a neuropsychological evaluation where cognitive impairment is suspected?
Yeah, so a neuropsych evaluation is really like kind of going back to grade school. So a lot of times what we do is we will have people do a neuropsych evaluation. It's like paper and pencil tests, things like that. And we assess all of the domains that I've talked about. Some of the other things that we do is we will sit down with for an interview with both the patient as well as a informant. So think about like a spouse, adult child, caregiver, anything like that, somebody who knows them well. And we ask them all sorts of questions. We ask questions about your medical health, including vitamin B12, diabetes history, hypertension. We ask everything about your mental health, treatment, see if there's any neuroimaging available. We ask about sleep. We even ask about, in some cases, your childhood, right? Were you born prematurely? How was your education? What level of education did you attain? Your occupational history. Some of the demographic factors can inform decline and or protective factors. So we want to basically get to know a person head to toe, inside out. And then we take all of that information and we combine it into a report, because every person is such an individual and all of their individual factors inform what's happening, right? A test result for, say, you, Megan, or myself, if we get the same exact test results, that may not mean the same exact thing, right? We're different people, different demographic backgrounds, different ages, all of those things. We want to make different health history, and that can impact what these things should look like as well. So we do lots of integration and have a chat. So after everything is said and done, we bring people back and we discuss what we think is causing some of their concerns, whether it's even just normal, right? Which is great to hear. If it's not, what do we think is causing it? And what are some recommendations? Like, what do we think are some next steps and some things that you can do to optimize your brain health?
Yeah, great. And then how can receiving a diagnosis help a person in their family? And you talked a little bit about this, but maybe you can expand on it.
Yeah, I know that receiving a diagnosis can be heartbreaking, overwhelming, and in a lot of ways feel like some of the worst news that somebody can possibly receive, right? So it's really hard to say, like, how is this helpful, right? But it is helpful in that at some point people realize that something is happening and they don't know why. And so this can provide some answers as to what and why. So if there's any changes in behavior or any changes in their ability to live independently, why is that happening? And so it's nice to provide some answers for those things. A diagnosis also provides access to resources. So things like support groups, caregiver support, adult daycares, respite care, specific medications and or treatments, right? A diagnosis can also differentiate, right? Is this severe depression? Is this Alzheimer's disease, right? Because in the real world, they look a lot alike until we get a pattern on our testing that we can differentiate these things. And so treating depression is going to look different than treating Alzheimer's disease, right? So we want to make sure that we guide them in the correct areas. A diagnosis can also help people kind of figure out their end of life goals and wishes, right? So as we catch these things, the goal is always to catch them a little bit earlier. But this allows patients to kind of age with dignity in a lot of ways. So they can assure that all of their affairs are in order. They can also spend time informing their friends and family of their diagnosis. And this allows them as a family unit to kind of process what this means and these changes. And in a lot of ways, people can make some big changes, like, oh, let's do Disneyland more often, or let's spend the holidays together, and being more mindful about their relationships with one another.
Right. Great. So not only, I mean, we're sort of talking about neuropsychology from a clinical perspective, but you also do research. You're the neuropsychologist for the Alzheimer's Disease Research Center. So you do a lot of testing, you make a lot of research diagnoses, and I kind of want to talk a little bit about that.
Okay. Well, I'll first talk about how a diagnosis is made from a clinical perspective,
Yeah.
and then a little bit about our research.
Yeah.
So as I mentioned before, it's very integrative. We take all of the information about our patients and combine it. For their testing, we do test all of the domains I talked about before. And then we do a statistical analysis. And I really want to emphasize that because after testing, everybody's like, how did I do? Did I fail? Did I pass? How did I do? And I honestly can't tell you in a lot of ways because I see people between 50 to 90 years old and I don't have all of the statistical analyses memorized. So the goal is to compare this person to their same age peers, right? So normative data that's most similar to them, whether it's age, gender, level of education. Okay. And then I evaluate all of that together. And so usually a diagnosis is made based on that. One of the key factors about a diagnosis is actually how well a person can live independently. So can they still bathe independently without prompting, feed themselves, groom, toilet? Can they manage their finances, drive independently without any errors or accidents? Can they manage their medications? All of those things independently. And so if there's any variability in that, that also helps us inform sometimes the severity of the illness. So we take all of that and kind of that's how a diagnosis is made. In our actual UCI Mind Research Center, it's even more integrative in that we meet with our medical doctors as well. So every week we have what's called case conferencing, and we all, myself and Dr. Corona, our other neuropsychologist here, we will present these cases. Everything from, a 75-year-old white female with this many years of education, medical history, all of those things, their test results, and the neurologist will have likely seen them as well. And then we talk about it and we assess it and say, what do we think is happening? These are their concerns, these are their family members' concerns, and then that's how we kind of come up with a diagnosis here. So it's really nice to have an extra set of brains in the room as well, and from people who are from different specialties, right? Neurology is there, geriatric psychiatry is there, nurse practitioners join in who see our patients as well. So it's very integrative. But I think it's also really important to know that these are, in a sense, a hypothetical diagnoses. Because an official confirmatory diagnosis is not possible until after a person passes away, right? So we can't say for certain what this is. We can say based on the research, based on these things, we think it's Alzheimer's disease. But there are instances when somebody's diagnosed with Alzheimer's disease, and then upon autopsy, their brain reveals the diagnosis of, vascular dementia or Alzheimer's disease. And that's not what the pattern look like, and that's not what the things look like in the day-to-day life. And I like to compare it kind of like diagnosing different types of cancer, right? You biopsy those cells and you figure out what type of cancer it is, right? But it's really hard to go into the brain and biopsy a piece of the brain while somebody's up, walking, talking. That can lead to some really unfortunate consequences, right? And we don't want to do that. You're already concerned about how your brain is functioning. Let's not add insult to injury and make it worse. So the only way that we can actually diagnose it at a cellular level is at autopsy, which is unfortunate. We're working towards, I think, every major medical university and clinic around the world is working to being more valid and accurate in their diagnosis. And that's just the hard part about the brain. It's so tricky.
How often, and maybe you don't know the answer, but what's the frequency that clinical diagnoses are correct for, let's say, Alzheimer's disease?
Usually they're pretty accurate. It's pretty well researched. On occasion, there will be like an additional diagnosis on top of that. So Alzheimer's is frequently co-occurring with some other diagnoses like vascular dementia, right? Or dementia with Lewy bodies. These things can frequently co-occur, and one is happening before the other one starts. So by the time a brain gets to pathology, they'll look at it and they'll say, there was two of these things happening. And so that happens quite frequently as well.
We do have a question about fluid biomarkers, and perhaps you're not the best person to ask, but the question is, are there any blood biomarkers yet for mild cognitive impairment? But they're probably asking about Alzheimer's disease. Before you start, I would say one good place to go is we had a conference this year, our annual conference, and there was a presentation by Dr. Sid O'Brien who tried to address this and because it's a common question that comes up. But Dr. McDonald, I don't know if you have anything to add to that.
Yeah, I mean, right now, some of the bigger biomarkers that are being used can be like CSF, like so cerebral spinal fluid. And even then, it's not super predictive of functional or symptomatic concerns.
Okay.
So it's still not a perfect science. There is some, more evidence towards some things like ApoE4 burden. Are you carrying two versions of the ApoE4 allele? That's going to be a bit more predictive. But when it comes to like mixing your alleles, that's not super predictive. You can have somebody who has an ApoE4, which is highly increases your risk for getting Alzheimer's disease a bit more, and then like an ApoE2 allele, and then never display any clinical signs or symptoms. So there's still a lot unknown, but I'm not the expert on that. You're gonna I reference the talk that you mentioned. I think Sid O'Brien's gonna know way more.
Right, and I think it's important, and maybe you can confirm this, that pairing biomarker testing with like a clinical assessment is sort of ideal. Would you agree with that, or?
Yes. Yeah, I think that it can be really challenging to get some biomarkers depending on the facility that you're a patient for. Our clinic, it seems to be a little bit easier, right? It's included in research, but in other clinics, it's not quite. So, for example, if you're a veteran at a VA, it may not be as easy to get some of those biomarkers because they don't necessarily inform diagnosis as much. So it's hard to get that care covered. But if you can get them done together, I would do that. I would never want to have somebody take a look at biomarkers and assume that they have a diagnosis, because we know that even if people are carrying some of those biomarkers, all that really means is we're at an increased risk of displaying symptoms. We don't know when that's going to happen. We don't know if that's going to happen. It's just an increased risk. So if we can get some neuropsych data on them and do those things, that will be a bit more confirmatory.
Great. Okay, I'm going to throw a curveball at you here.
Ooh, okay.
I know you're starting some research. Can you describe just quickly the type of research that you're doing at the Alzheimer's Disease Research Center?
Yeah, we're really interested. I mean, we're so fortunate as a center to have a patient population that's diverse and a patient population that has different attainments of language, right? There are so many people who speak more than 1, 2, 3 languages, and they learned English at different times. Unfortunately, all of our testing is done in English. So what does that mean? I cannot possibly compare language results for two different people, one who's primarily English speaking and one who's primarily Mandarin speaking, right? It's not fair for me to compare their language scores and say that these two things are the same. So we're trying to look and see if being able to parse this out a little bit more and figuring out, like, when did you learn English? Your level of comfortability with either language, does that predict the scores? And should we be creating different tests or even different normative data for people who are bilingual? Yeah.
Great. Okay, well, with that, let's wrap up. Dr. McDonald, thank you for joining us. We have to have you back. You had so many great answers for us, so thank you. And thank you to all of those who attended live today. You can access this and past Ask the Doc episodes, podcasts, and more on our YouTube channel and on our website at mind.uci.edu/mindcast. Or is that /? I'm not sure. Please join us in December for a discussion on Parkinson's disease with the Chair of Neurology, Dr. Claire Hinchcliffe. And to learn more about research at UCI Mind, you can visit our website or consider signing up for the UCI Consent to Contact, or C2C registry. Signing up at C2C is free and confidential. and allows you to be matched with research studies that might be appropriate for you. Take care, and we'll see you soon for Ask the Doc on UCI Mindcast.